Welcome to Robert Wood Johnson University Hospital Somerset Health Talk. I'm Dr. Douglas Ashinsky of Robert Wood Johnson Physician Enterprises, Warren Internal Medicine. It is important for all of us, no matter what our age, to think about our wishes for end-of-life care. If we are facing a serious illness, what type of treatment do we want? What options are available for pain relief while also helping us improve our quality of life? How do I make my wishes known? On today's show, we will discuss palliative care and advanced care planning with our two special guests, Dr. Marc Milano, Medical Director of Robert Wood Johnson University Hospital Somerset's Emergency Room Department, and Megan Allen, a registered nurse who's the Performance Improvement Coordinator of Robert Wood Johnson University Hospital Somerset. First, the audience is going to have a couple of questions, so let's ask, tell me a little bit about yourself, your background, and where you're currently working as part of Robert Wood Johnson Somerset.
Again, thank you for the introduction. I'm Marc Milano. I'm the Medical Director of the Emergency Department at Robert Wood Johnson University Hospital Somerset. I'm also Regional Director for the Healthcare Systems Emergency Departments in the Southern region.
The Southern region meaning?
From Somerset all the way down through Community Medical Center, and I've been at Somerset for 15 years now.
Okay, congratulations on doing that. And?
Yes, I'm Megan Allen. I'm a registered nurse, and I work in the Quality Improvement Department at Robert Wood Johnson Somerset. I've been there for about 15 years, and my role is to improve the care of patients at the hospital and provide opportunities for them to have safer care.
Thank you also, and thank you for all of your service at Robert Wood Johnson Somerset. Now, this is not an easy subject for most physicians to talk about. Palliative care and advanced care. First of all, they're not the same. Can so either of you explain what palliative care is and what advanced care is?
Sure. Palliative care is a focused, specialized area of medicine that helps patients that have a chronic condition or a serious medical condition have an improvement in
the quality of life.
In the quality of life, yes. It helps to provide the suffering, a relief of suffering associated with those conditions.
And advanced care planning?
Yes, so that's determining what type of care you may want in the future ahead of time before it becomes an emergency.
So as a primary care physician, this is something that I'm supposed to discuss with my patients, especially as they get older. Also, if they have any chronic type of conditions such as heart disease, diabetes, COPD, asthma, or anyone who's been recently to an emergency room or has been hospitalized. And the problem with most physicians is they have a very difficult time in discussing either of the two.
Yes, that's correct.
I mean, I would imagine in your practice, just the time that it might take to have a conversation like this. These are often elaborate conversations that really are time consuming and require a tremendous amount of attention from both you and the patient. So I imagine the time constraints of practice in 2019 probably make it very challenging to begin with. But again, it's incumbent on us to make that effort. And part of the reason I'm here today to talk about this is because I think there's even room for this in the emergency department. Again, we have maybe even more compressed time frames and more acute conditions that we take care of in the emergency department setting. But I believe that with the right tools and the right knowledge and the right intentions, we can begin to engage patients and their families in these conversations.
It's actually not the time that it is. In this type of age, especially with computers, et cetera, it's not the time that it takes. The time is actually there if you make the time. Right. It's the discussion itself. It's not easy to speak to a 60-year-old who's sitting in front of you, who's telling you all about their grandchildren, and to say to them, okay, God forbid something happens to you, what would you like me to do? And the patient themselves, when they hear that, the first thing they're going to think of is, oh my God, is he not telling me something? Is something going on? Or why is he even asking me something like this? I'm going to be around for the next 40 years. I'm going to see my grandkids graduate from college. Why is he even asking that? So the introduction of it is very difficult itself. Now, CMS has helped with Medicare people because in an annual wellness exam, as part of that annual wellness exam, you're supposed to discuss that with them. And New Jersey was very smart when they put together certain forms, et cetera, that I can actually take out and go over with them. So now let's go back that I haven't done that, or I've done it and it's in their EMR, but it's not necessarily following them to the emergency room. They get to the emergency room and what happens?
I think there's lots of different paths to the emergency department. First of all, there's the ambulatory pathway. Someone is brought there by car with family members, and it may or may not be with any level of preparation, or they could be brought by ambulance, which sometimes is even more emergent. And then there's a whole other bucket of patients that come from a nursing home or a skilled nursing facility. We hope that those patients will have something in place. We hope that part of the intake process to a nursing home, skilled nursing, or rehab will give that patient an opportunity to make those decisions. The other patients, it is very challenging, and many times they're not prepared. These are things that obviously they didn't wake up today knowing that we're going to wind up in my emergency department with a life-threatening emergency that they might not even know is life-threatening. But again, we have the ability to recognize these things. And again, you talked about the EMR, Dr. Ashinsky. The EMR is an invaluable tool to us, and it's very frequent, if not always, that we look at those patients' histories before we go in to see them, right? So if we have the time to do a little bit of research, we always do. And I can see when a patient has been to the ED 7 times in the last year. And then I look to see, do they have an advanced directive? Do they have a POLST form, which we need to talk about a little bit? But if they don't, I feel like it's my responsibility at least to start that conversation. I may not get the form signed, but what we have now at Somerset, and Megan will talk about that a little bit more, is our palliative care team. We have a service now at the hospital that allows us to say, all right, I don't know everything about this. I'm not an expert in it, but I do know this patient would benefit. And now I can hand that patient off to the primary care team or the palliative care team to say, it's time for you to get involved and help us figure out what this patient needs and help this patient and their family walk through a very difficult time. So whereas you in the office kind of have to do that for yourself, I can actually hand that off to the team in the hospital, who's fantastic at doing that. Megan was a huge part of making that all happen and putting that team together for us.
You want to tell us a little bit about that?
Sure. Well, palliative care is a medical specialty. And really, the palliative care team that we have is comprised of an advanced practice nurse as well as a chaplain. And they see patients and their families when there is a concern or if there is a question about goals of care or if there is tragedy. They also see patients for advanced care planning. They create POLST forms with patients as well as advanced directives. So they really are a fantastic addition to our team at Robert Wood Johnson Somerset to help out with our patient care and ultimately the patient experience because really we want to make sure that our patients have that good experience and that we are giving them care consistent with what they would like.
So again, we're looking for the patient to have quality care through their physician, nurses, but we're also looking for the patient to experience a good experience while they're in the emergency room or at the physician's office, et cetera. Because if they have that good experience, they will be able to follow the suggestions given to them by the emergency room physician and or the palliative care team. And again, palliative care, we're talking about people who have chronic conditions. We're not talking about advanced directives initially. We're talking about how do we get them through the events in their life. They've got a chronic disease, something acute happens on top of it. How do you want us to be able to treat you by giving you the appropriate treatments modalities, whether it's medications, whether it's referral to a pain management specialist, whether it's a referral for someone to be given trigger point injections, or et cetera. It may even be just a suggestion of seeing a physical therapist.
Mm-hmm.
Absolutely.
And again, we do this in an office setting like I do in my office, but unfortunately a lot of people come into the emergency room in an emergency, not having brought any of that stuff with them.
Mm-hmm.
Or sometimes not even having had that conversation prior or thought about it. So I can actually give you a little anecdote of a case that I recently saw in the emergency department. Now, last time we were here, we actually talked about sepsis, and it keeps coming back. But we had a patient come to the emergency department at Somerset several weeks ago who came with sepsis, but the backdrop for that patient was she had pretty severe and advancing dementia. And there were a number of family members who were deeply involved with her. Clearly, they loved her dearly, and they wanted the best for her. But yet, they loved her so much, they didn't want to think about her eventually moving on and passing away, so that they failed to have that conversation. They brought her to the emergency department. She had a high fever. She was a bit delirious. And as the family members came in succession, and I sort of met with each one of them, I started to realize, they're really desperate, but they don't have a plan. So I started that conversation. I said, have you talked about what you want to do with Mom? And at first I got a lot of blank stares, and I said, well, she's really sick. I think sometimes we have to let people know that, like, this doesn't look good. She may not survive this hospitalization. So what do we want to do during the course of her care? Do we want to work on making her comfortable? Or do we want to be really aggressive and do things like put her on a breathing machine or put IVs into her neck? And after I made it a little bit graphic, but really something they could understand, I got consensus from them. At that point, I made a call to the palliative care team, and Raul came down, our chaplain, and he was able to secure a pulsed form, and we went over it with the family together, and they signed it. The patient was...
And what the audience needs to understand is just because you're getting a palliative care agreement or palliative care doesn't mean we're not going to stop treating you.
Precisely.
We're going to still be treating you. And again, the whole idea of all of this, both palliative care and advanced care, is that the patient's wishes are followed. So if they want to be as aggressive as possible, we will be as aggressive as possible and follow what they're doing. If they understand that their life expectancy is not a long life expectancy, that we will possibly treat acute problems such as the sepsis. But if they need to be put on a breathing tube, they don't want to be put on a breathing tube. And what we were looking for is we want to achieve the medical care, but also the quality of life, and give them whatever quality of life they desire.
That's correct.
The beauty of the pulsed form. And for those that don't know about it, I mean, we should probably discuss it. It's a one-page simplified form. It doesn't have legal jargon on it. It asks very specific questions in terms of what people want and don't want. Do you want artificial nutrition, or do you not want that? Do you want intravenous fluids, or do you not want that? Do you want to be placed on a ventilator? So I think that form alone has simplified things for us and for patients because it's in plain English for the most part, and it really gives us actionable steps that cross medical settings. So if we do that in the hospital, as we know, legally in the state of New Jersey, that form crosses different lines of care. So if they go to the facility, the nursing home from the hospital, that form should stand and be able to continue to guide their care as to what they want and do not want.
Again, New Jersey was smart by putting together this New Jersey pulsed form. When you go to your primary care office, you can ask them to actually see one. Usually it'll be a green form. It's a 2-page form. The second side is the instructions. The first side says exactly what you're looking for. And it'll tell you. And again, this is more for the advanced care planning. So this is when you're discussing whether you want to be treated aggressively with first IVs, IV antibiotics, whether you want nutritional therapy, whether you want nutritional therapy via an NG tube through the nose down to the chest, or if you want to have it through an intravenous. Also, if you want to be placed on a respirator or a breathing instrument, or if you want to, if you need CPR, whether or not you you want CPR or not. And what's important about it is this green form follows you to every place that you go. So you can sign that at home, and that follows you to the emergency room. That follows you through the hospitalization. If you need to go to a rehab, it follows you through a rehab. If you need to go to a nursing home or a skilled nursing facility, it follows you there. And then when you're discharged home, it'll follow you there also. The other thing is it's not written in blood, meaning that it can be changed anytime you want to change it.
Yeah, I think that the revocability of it is something that I think gives patients security, that this isn't a dead end for them, that if they do change their mind and their wishes change, they have the ability to change that whenever they would like. If they want to change that every other month, they can do that. Certainly we wouldn't suggest them doing that, but it is possible. So I think to roll back to something you said earlier on about having that conversation with the vital, healthy, vigorous 60-year-old, I think I would look at it more as a conversation of, let's do this so we don't have to worry about it. Let's take this off your to-do list in life so that you're able to think and focus on the things that you really want to, as opposed to the things you might have to someday. So, and I also think when I have that conversation, it's, let's not put the burden on your family when and if something happens. Let's keep that something that you decided so that they don't have to make these difficult decisions on your behalf. Because I think I would personally want to make sure that I didn't put this on my wife or children or any of my other family members when and if something like that were to happen.
Well, that's why it's not only important to fill out the pulse form, but to go over what your thoughts, desires are with your family members. Because the hardest thing in the world is when you're in the emergency room or in the hospital and something is happening, to the family, then one says yes, one says no, one says maybe, one says this. If everyone is on the same page, then that person's quality of life and their desires can be followed.
That's an excellent point. And that's where the palliative care service really comes in, is because they will make those phone calls, they will make the connections with all those important decision makers in someone's life so that there is consensus, and that at the last moment or when the heat of the issue occurs, there isn't this dissension in the ranks. It's, well, Joe wanted that and Sally wanted this. It's we've had a conversation, we're all on the same page, and we're confident that we're going to proceed in this direction. Really what I believe to be the patient's best interest.
And again, with you setting up the palliative care team, such an important thing to help improve the quality of the person's end of life.
Absolutely. And really, planning ahead, I think, gives a lot of peace of mind, not only to patients, but to their families. Knowing what your wishes are is so important. My daughter is actually heading to college this summer, and I did have a discussion with her about advanced care planning. So while it's, kind of crazy to have this idea or this discussion with an 18-year-old, really, I think it's such an important conversation that you need to have that. You need to be able to share that information way ahead of time. I mean, unfortunately, Dr. Milano knows when tragedy occurs, patients end up in the emergency room, and really having these discussions and planning ahead helps make the experience for the patient and their family so much better. So.
Well, you have to think about this almost like, again, as a mother with an 18-year-old. You're really not advanced care planning. What you're doing is you're finding out what their wishes and desires are. You're giving them guidance onto what to do in college, what to do in case something happens, so that they know what is right and what is wrong. In addition, you're hearing from them what their opinion is, so that when something happens, you can follow what they would have wanted you to do.
Right.
Absolutely. And I think that really brings up an important point, that really it's something to think about or reconsider. As you said, it's revocable, it's modifiable. It's really something maybe to look at in terms of the different milestones in one's life. So whereas Megan is talking about it with her daughter going to college, maybe it's something you talk about when you get married. Maybe it's something to talk about again when you have your children, and so on and so forth. So I think even though we look at it as something that's durable, it can be changed, and maybe those are the hallmarks of life where we want to start looking at, okay, now it's time. Did something change in how I feel and what I want?
Well, just like when there's a change in life and you get new insurance or you get a will.
Precisely.
You should think about periodically that.
Absolutely, it's definitely a fluid document. I mean, like you said, it's not written in blood. I mean, this is certainly something that you can change, you can modify, that you may have a particular desire based on how you feel today. And if you're diagnosed with a different condition a couple months from now, a couple of years from now, your opinion may change. And we certainly respect that and want to be sure that, again, we're providing the care to the patient that's consistent with their wishes. So absolutely, advanced care planning is essential to care for patients in the hospital. So,
and as I said, CMS, when they started the Medicare annual wellness, included that as part of their annual wellness. So anyone who is a Medicare patient who's going into their doctor's office for an annual wellness should think about talking to them about it. They should also think about asking them for a copy of the pulse form. Whether it's green or whether it's white, it's still going to be equally effective. Do not fill it out at the time of the visit. As I said, what I give to the people is I give them the form itself with the instructions. I also give them, New Jersey has a very nice 5-page all about advanced care planning itself, which explains what each part of whether it's IV fluids, IV antibiotics, treatment, aggressive treatment, etc. They have all of that information. Then they can take that home, discuss it with their spouse, discuss it with their family, come up with a decision. And the nice thing is they sign it, they bring it to me, I sign it, it becomes part of their chart. They keep the original, and they know that it's always revocable. They all know that it's always easily to change, and that it's nothing written in stone. No lawyer needs to be contacted. No money needs to be spent to do it. And what you're doing is you're allowing them to follow their wishes.
Absolutely. And that's also a really good point you bring up, Dr. Ashinsky. Some of the advanced directives, living wills that we used to talk about really are very difficult to understand. I certainly don't understand them. I don't have a legal background, and I would imagine even patients, once they've got those completed with their attorney, they could read them and basically not even know what they signed. Whereas the post form is so much more actionable, so much more digestible, and again, so much more flexible.
And again, the whole idea is that we're following the wishes of what the patient desires. And with palliative care, again, what we're doing is we're allowing them to obtain pain relief, treatment of the disease, and have the backing of the community, having a backing of religious leaders if necessary, and be treated appropriately.
Absolutely.
Totally multidisciplinary. We were actually talking about, what does palliative care look like to a patient and their family? And I look at it as just a big hug, reaching around the patient and their family members, providing everything from respite care to the caregivers themselves to pain control for the patients, things like aromatherapy, massage therapy, anything that can make you more comfortable in your time of need and your time of distress is really what palliative care can embody. I think it's a very fluid domain, in fact, so that I don't want to make people think that palliative care is a morphine drip, because it's not. And I think that's a really important thing we need to bring up, is the distinction between palliative care and hospice care. Because occasionally when you start to have that conversation, and I'm sure you've probably had that same thing, where you talk about palliative care and the patient immediately thinks, am I dying? Is there something that's catastrophic? And really, the distinction between palliative care and hospice is huge. Hospice care is a subset of palliative care, right?
If you imagine a target, right, and with a bullseye in the center, the large target is palliative care, and hospice is just a very tiny bullseye subset of palliative care. Really, it's about quality of life, identifying patients' wishes, and providing care that's consistent with those wishes.
And palliative care doesn't mean that they're moving on to hospice care or advanced care. It means that you're trying to give them the quality that they have, sustaining them, keeping them with as minimal pain as possible, using the multidisciplinary approach.
Yes, absolutely. And there's many diagnoses that palliative care benefits. It's not just for cancer. I think there is a misnomer out in the public about that it's specifically for cancer, that's about hospice, and that's entirely not true. So many conditions can benefit from palliative care, whether it's congestive heart failure, COPD, sepsis, as we mentioned, Alzheimer's disease, dementia, all of these different conditions. Thanks to modern medicine, you can live for many, many years and have a very happy life. Palliative care comes along to support you during that time. And really, it's not dependent on diagnosis, it's not dependent upon age, and really it should be initiated alongside the diagnosis. But again, it could be initiated at any point in time during the treatment of those conditions.
And as you said, we're not looking for this to lead to hospice or advanced care. We're looking for this to give the person the best quality of life that they have with chronic conditions, which could last 20, 30 years.
Yes.
We're looking so that that person isn't being put on a morphine drip, and maybe what they need is physical therapy. Mm-hmm. Maybe what they need is a wheelchair. Maybe what they need is a cane. Mm-hmm. Maybe what they need is a walking cane, and simple little things. Mm-hmm. Maybe what it means is having someone, a social worker, come out to the house, making sure that they've got railings on the sides of their staircases, that the bathrooms have railings there. It's the whole social aspect of it, mm-hmm. not only the medical aspect of it.
Absolutely.
It's giving choice. It really is. It's supporting the patient in the way that they want or need to be supported. So if somebody says, I want to be at home during the course of my illness, then we want to do things that we can do to support that. So maybe it's having home health aide come out and ensure that they're getting their medications on a regular basis, or that they're weighing them to make sure that they're not gaining weight with their congestive heart failure. Mm-hmm. So I think these are all these adjunctive things that palliative care encompasses that truly do improve quality of life throughout the entire spectrum and continuum of illness.
And down the road, I expect to see more things like telehealth as part of palliative care, because being able to take out your iPhone or opening up a screen to be able to see how the person is doing mm-hmm. actually will help benefit the palliative care team itself.
Yes, it truly is a holistic approach to medical treatment. It really is, combining the entire patient in their care. I mean, bringing in the family, because the illness doesn't just affect the patient, it affects their family as well. So looking at that whole spectrum and treating the patient in the entirety is really the focus of palliative care. So.
And the other thing that's helpful is if it's just a husband and a wife and one of them is sick, it gives them the extra backup, so that that person, it doesn't feel like they're at wit's end, that something's going on and they can't do something because they're so stuck on something.
Yep.
Absolutely.
And again, hoping that more and more of us discuss this more and more with the patients who have chronic illnesses, mm-hmm. allows us the ability to improve their quality of life, whether it's 30 years, 40 years, or for the person with an advanced directive, less than 6 months. Mm-hmm. It allows us to take care of them and to give them the best care possible and allow that person that quality.
Absolutely.
Yeah, I really see this as the embodiment of our modern healthcare. You know, the goals and intentions of our Affordable Health Care Act had a lot to do with medically centered patient homes and community health. this is really a way that we can start to reach out into the communities and take care of patients and their families where they want to be taken care of in the way that they want to be taken care of. So I really do think that if you want to talk about offshoots of our current healthcare system that have been successful or provided for a betterment of patients' well-being, I think palliative care really is one of the most amazing examples of how things are working.
Well, the other thing that's really good about it is the fact that right now when you come into a doctor's office, all you see is computers. And what palliative care, advanced care, et cetera, does is it allows you to actually touch the person and give them that comfort and human touch that may or may not be missing in that person's life. And that touch means sometimes more than that EMR sitting behind the person with all of their lists of allergies, et cetera, and a smile on someone's face, or the fact that there's a religious person who's available and that you haven't been able to get to church or to temple or to anywhere because of the chronic disease, gives you that little bit that reminds us we are all human beings.
Absolutely.
It gives the human touch to the medical care.
It's a great point.
Any last thoughts?
Well, if you or a loved one does have serious illness, it's important to talk to your doctor or to your nurse about palliative care and see if maybe it may be right for you. Again, it improves the quality of life, and really the focus is to provide that holistic approach to patients and support them throughout the trajectory of their illness.
Thank you both for being here. This concludes today's episode of Robert Wood Johnson University Hospital Somerset's Health Talk. Please remember the opinions expressed here by our medical experts are not a substitute for medical advice from your own physician. If you need a physician, please call our physician referral line at 1-888-724-7123. For more information about Robert Wood Johnson University Hospital Somerset, please visit our website at www.rwjbh.org/Somerset. Thank you so much for what you do. Thank you for so much what you bring to the table, and thank you for improving the quality of our healthcare system.